Hello and welcome to another episode of Idioms of Normality, brought to you by Timeframe TV and Traces.Dreams. I'm joined today by Greg Fox. Welcome.
Thank you.
Before I get started, what perspectives and experiences do you bring to the question, what is normal?
So there are two things which I think frame my thinking about normal. One is my role as a physician. So I'm trained as a respiratory physician, which means that I treat people with lung disease, and in particular, the infectious lung disease is called tuberculosis. And so that definitely informs the way that I think about what is normal. And then secondly, I'm an epidemiologist, which is somebody who looks at populations and works out how to describe populations using information and data, and tries to use that to go and predict risk of disease or risk of certain trends in the population.
Okay, so both a lung specialist and an epidemiologist.
That's right.
So what is normal?
It's actually a really difficult question to answer, both as a physician and as an epidemiologist, because essentially we are, through research, through measuring things, trying to work out what normal is. And at the end of the day, we can never know what it is, but we try and approximate it through the method that we use. I'll just give you an example. So when a patient has been smoking for a long time, we do a certain set of tests called lung function tests, which measure the volume of air that a person can breathe out and measures the volume of their lungs. And if somebody's been smoking for a long time, then we want to work out, well, is this person's lung function less than normal? Okay, but the question is, well, what is normal? And what is normal for the person is going to vary. So it depends upon how tall they are, what their age is, what their ethnicity is. All of those things have to be taken into account. And so as a physician, what we have is we have some standard results, which we use to measure that person's lung function against a standard population just like them. And so we can say if a person lies outside of the range that a normal population or normal healthy population has, then they have abnormal lung function. And that's really important, because if somebody has low lung function, say they have evidence of obstructive lung disease, then that may mean that they need a treatment. Whereas if they have normal lung function, then we may not offer the same treatment. But the challenge is that, of course, everybody's a bit different. And so how do you actually work out where on that range of normal values a person should lie? The way that we measure normal in medicine is using something called normal distribution, which is, you might have heard of a bell curve. So it's a way of looking at a whole population and saying, well, we think that in the middle there's a common value that is most popular, and then on either end there are less common values. And so that normal distribution tends to be how we measure things like lung function. And so when we're wanting to compare a person within a population, we take that bell curve that has been derived, and then we apply it to that person. The thing about normal, though, in medicine is that there's always going to be somebody right out on one end or right out on the other end. And so just because your value of your lung function test happens to be slightly above normal, for example, that may just be a random variation because of who you happen to be. So I guess what I'm saying is it's really hard to work out what normal is, even when we're trying to measure it.
There seems to be a few factors that are brought into that calculation or that diagnostic, and that is variable factors throughout that person's lifetime, unknown factors as well that might push them into being an outlier. The normal distribution, is that related to the average, or is that related to frequency? I mean, there's obviously very purposeful calculations for the normal distribution. And it's not always a perfect bell curve, but is it a measure of frequency? So if we encounter this particular degree of lung function frequently, do we then call that the normal? Or if it's an approximation of what we find as the middle value within a population, is that what we're looking at?
The normal distribution essentially is a plot of frequency in comparison to the distribution in that population. And we measure that by using a thing called a standard deviation. So the mean would be right in the middle, and then we'd say that something is either below or above that mean by a certain number of standard deviations. And we tend to say that something that is 1.96 times the standard deviation above or below, that is sort of the cut point for what we call the normal range. And so if somebody is above or below that cut point, then they're outside of normal. Now, that is, as I said at the start, something we don't really know. We're just trying to approximate it based upon, a standard formula. And so blood pressure, for example, seems to fit pretty well into that normal distribution. But there are some things which don't fit very well at all. For example, if you think of in certain populations that we look at, patients who've got tuberculosis. So if we think about tuberculosis infection, tuberculosis is a lung infection which is transmitted through the air. We have a way of measuring whether a person's been infected, which is called a tuberculin skin test. And that skin test measures whether a person does or doesn't have evidence of infection. We know that if you take a whole population, that most people have a very low measurement on that test, and there's a very small number who have a very high measurement. And so, in other words, that normal distribution is quite skewed in that population. So that you'd say that was skewed right because the distribution is not symmetrical. So in that case, you have to change the way that you fit the curve to that population based upon what you actually measure. It doesn't fit that sort of same normal distribution that, say, blood pressure might.
There's a few different pathways that I'd love to pick up on, and whichever of those you want to run down, we can run down those. One is, I think it's really interesting that we've got a calculation for what we might consider normal within a patient, but normal doesn't necessarily equate with health. It doesn't necessarily equate with lifestyle. Just because someone is abnormal doesn't mean they can't lead a healthy lifestyle. And just because someone is normal doesn't necessarily mean that they're entirely healthy. And of course, when we're talking about normal distribution in terms of lung function, we're talking about one particular organ. We're not talking about the body as a system or their social relationships, etc. So there's quite a lot of things that we can unpack there, because if we limit ourselves to just the calculation, then we miss out on all these related, but somehow, because of the way I've asked the question, they become peripheral. Maybe I'll prompt you on that before talking more about tuberculosis, because I'd love to ask you some more questions about tuberculosis as well.
Sure. Yeah. I think the point you make is an important one. So when we measure things in medicine, we are essentially simplifying things, because in one way, the complexity is actually in some ways too difficult to deal with. And so we try and work out, okay, what is the most important measurement that will help us to answer this question? And what do we think is the relationship between this one individual and a group of individuals like this person? And so if we take lung function as an example, I certainly see patients in my clinic who've been smoking all their lives and they have lung function which measures as normal. And so in that case, that test may be useful in telling me that person has not been severely affected by their smoking. That doesn't tell me, though, that they have had no effect of their smoking. It doesn't tell me whether before they started smoking, they may have been quite above normal, and then the effect of the smoking has just brought them back into the sort of mean value for that population. So, in other words, to be able to understand an individual within the context of this distribution, you need to not only know something about them, but perhaps also know something about what happens over time as well. So trends are important. If you had somebody who started off with a very high lung function, high forced expiratory volume, and then that came down to the middle or lower level of normal, but still within normal, that might actually indicate, some disease which is quite significant, even if they don't actually meet the criteria for abnormal.
In the laboratory and in the clinic, this seems like an appropriate usage of calculations, and it seems to serve the function of helping the doctor help the patient. What are your views on when the word normal jumps out of the laboratory and the clinic, when it becomes popularized and, someone leaves the clinic and says to their family, oh, the doctor said I'm not normal? It takes on a different value, doesn't it?
It does. And I think when I think of patients who are being tested, often what they want to hear is, doctor, is this normal or is this not normal? And I think the reason they're asking that is because they want to be reassured. They want to know what their own situation is in comparison to everybody who is like them in the population. And the problem is sometimes it's really hard to give a definitive answer to that question. So, for example, sometimes if a person has a spot on their lungs, for example, that may be on the scan that they've had, they might show a small nodule and they might be sent to see a lung doctor, and they might, ask that doctor, well, doctor, is that normal? Is that just an incidental finding, or is that something much more serious? And sometimes it's difficult to say. If you have a very small nodule, it could just be because of an old infection, pneumonia that has occurred when they're a kid, and it's just formed a scar there, just like you get scars on your skin after you have a cut. But in somebody who's got a high risk of having a lung cancer, somebody who's been smoking for many years, that nodule might have more significance. And so we can't necessarily tell there and then whether that nodule is actually normal or whether that is something to be concerned about. And so in that situation, as doctors, we often will follow it to see what happens over time. And then if there's no change over a matter of months or years, then we say, look, this is not a pathology. This is just a, normal finding. And so we don't need to worry about it. But there may be some red flags which might require more urgent treatment or investigation and then treatment.
So interestingly, someone's health or their diagnosis cannot be reduced to an X-ray. It needs to be triangulated with other factors from the patient, where they grew up, perhaps. Did they grow up in a country that had a high burden of tuberculosis? Did they grow up smoking a lot? Were they in a high polluted area? It sounds like you can't, reducing someone's health or reducing something about a person to a simple calculation, whether that's an X-ray or where they sit on a bell curve, is not necessarily a good indicator of other things about that person or their prognosis for the future.
That's right. And it's important to take other information and to go and look at what that risk profile means for that one person. As an example, one of the technologies that's been developed recently to try and help to improve the accuracy of the way that we look at lung disease is a technology called CAD, or computer-aided diagnostics. And what that does is it takes a digital X-ray of a person's lungs or another part of their body, and it applies a computer algorithm to it, and it tries to work out whether the lungs are normal or whether there's an abnormality that might require further investigation. And the reason that computers are used is because often computers are actually more reliable than humans, and certainly more often reproducible in terms of the results that they give. But when you look at readings from those computer programs, it becomes complicated, because now we're not going to be looking at a yes or no answer, but we're going to be looking at a probability. And so the question that the computer program has to answer is there a high enough probability of there being an abnormality that this requires something further? And so for every X-ray, you'll have a probability that there is something that's abnormal or normal. And so this is, I guess, sort of the direction a lot of medicine is heading now, where we're using computers to do more and more. And ultimately, at this stage at least, it's difficult for computers to do all of that complex integration of the patient's circumstances and risk factors with the imaging. And so we have to combine those things together. And then that's the role at the moment of a doctor. But I think in the future, more of that will be automated to give us more quantitative measures of what risk actually is.
You give me so much to question, because on one hand, it's sort of the intuition that a doctor might have. The patient said something to me on this particular occasion. I want to follow that up. Can that intuition be turned into a statistical calculation that then gets put into CAD that can formalize these diagnostic gut feelings? It's challenging.
It can. There's actually a whole area of science which is developing now around how to communicate that risk. And so, as an example, there's been a paper published recently, Nature Medicine, looking at tuberculosis risk. And I mentioned before that tuberculosis is an infectious disease, and there's a lot of different factors that can influence your risk of getting that disease after you've been exposed to somebody else who's got the disease. And so we can take a whole bunch of factors, including a blood test or a skin test, but also their country of birth, their biological risk factors, like whether they've got a weakened immune system due to treatment, or maybe poorly controlled diabetes. And we put all of that information into a program where we can say, based upon all of your information, we think that you might have, a 5% chance of getting tuberculosis. Now, reducing all of that information down to a number can actually, on the one hand, it can make things clearer, because we can say, well, that means you've got a 95 in 100 chance of not getting tuberculosis. But for the individual patient, it actually requires some thought about how do we communicate that risk to the patient in a way that they understand. And so there's been a number of tools that have been now developed to try and help communicate risk to patients in a way that will allow them to make a meaningful decision. So in the example of tuberculosis infection, there's a program which is available on the web. You can type all this information and it'll give a visual depiction of 100 people, and then it will have a certain number of people red and a certain number green, so you can see what your risk might be. And then they'll also say, well, if you take the treatment to prevent tuberculosis, this is the number of people who might have a serious side effect. And so now you as the patient need to discuss with your doctor what is the risk of taking a treatment to prevent a condition which is uncommon, and what is the benefit. So how do you weigh those things up as patients? These days, certainly in countries like Australia, patients are very keen to participate and have information. But the question really is, how much information do the patients want to be able to make a decision, and at what point does it become confusing or overwhelming? And so that's the way in which we can use some of these algorithms and some of the computer software to try and help with that discussion and that understanding.
TB is an interesting one because not everyone who is infected goes on to become sick with tuberculosis. And I think that's something that fascinates me. It's not a one-to-one equation between you become infected with the microbes and then you become sick, which the popular model of germ theory is the normal course of disease is you are exposed to the disease and you become sick. But tuberculosis really adds nuance to that picture because there's all these different factors. You were talking about uncontrolled diabetes, immunocompromised patients, malnutrition. There's a whole host of other factors that can either increase or decrease someone's risk of progressing to a disease state. To my mind, I can't imagine that there is such a thing as a normal TB patient or a normal disease trajectory. Is that whole concept of normality worth throwing out the door when we talk about disease trajectory, when we talk about the progression from infection to symptoms?
I think it's certainly important that we have a more complex view than just to have this sort of binary idea of normal or abnormal. If you were to take the example of tuberculosis, if you look at what's normal, you would say, well, the norm, the most common outcome for a person who's been infected with tuberculosis is to remain well for the rest of their lives, to never get the disease. But that's not very helpful because for maybe 90% of people, they will remain well for the rest of their lives and never get disease if they've been infected. But for 10% of people, they will have particularly significant infection, progressing to disease, which, if not treated, could potentially be both life-threatening for them and also transmitted to other people. In other words, you've got two quite different pathways, one which is more common and then one which is less common, but potentially more serious. And so this is why I think this idea of a binary normal-abnormal is probably would limit our ability to take appropriate precautions in case of the risk for that minority of people who might be affected. And so it's important to understand for those who might be at a higher risk and more likely to be in that group, that they may need to take more urgent action. I think another similar example is actually the COVID pandemic. I think this idea of there being different pathways for different risk groups has actually been illustrated, and I think people have got to understand it a bit better because of what we've seen in our communities around the world. So we know from many different places that if you're a young, healthy person, that the normal thing for you if you get infected with COVID is for you to have some maybe minor symptoms, but very unlikely that you'll have to go to intensive care and very unlikely that you'll face a risk of death. If you're older and you have particular risk factors like pre-existing heart disease, or if you have hypertension or diabetes, then you have a much higher risk of having a poor outcome. And so I think through the way that the COVID pandemic has been covered in the popular press, I think people have come to understand that idea that there are certain risk factors which are important to understand, and that just trying to go and say either COVID is a minor illness which is not important, or to say COVID is going to kill everybody, neither of those views are very helpful. And therefore we need to be trying to understand, well, what can we do to, in an individual case, make sure that we protect people who are particularly vulnerable, and for people who may be personally not affected as badly to also consider what are the broader social consequences for other people as well if we don't take appropriate action to try and control spread from those people who have minimal symptoms.
It's quite interesting that, I mean, we're still kind of in the middle of this pandemic. Well, middle is perhaps the wrong word choice, but the pandemic is ongoing. And at the very beginning, doctors, to my mind, didn't know yet what a normal COVID patient looked like. But then the picture became very complex. It wasn't a normal COVID patient. It was there's a complex array of different kinds of COVID patient, and we can't simply understand the disease in terms of mortality. We actually have to understand the disease in terms of morbidity and the services that we have to provide for COVID. COVID, I mean, disrupted people's sense of normality and certainty on a social level. How did it play out for doctors and in the medical world?
I think, like everybody, overnight, all of a sudden we had to rethink how we did our everyday lives. Now, in terms of doctors working in a health system, that meant that all of a sudden we needed to start to take precautions both to protect the healthcare workers so that they could continue to deliver care, but also to try and protect patients. So if there was a patient who had infectious COVID in the hospital, that we would protect people who were not infected from becoming infected. And so I think, as you said, that the COVID pandemic, and particularly at the start when there was great uncertainty around its trajectory, I think that was a time of great uncertainty. And it's not that often, actually, that there's a new disease that suddenly emerges that's never been in the world before. And a disease like tuberculosis has been around for thousands of years. And so we have a pretty good understanding of the way it affects populations. Whereas in COVID, in the case of COVID-19, there was really no clear parallel. We tried to look for other diseases which might be a bit similar, like influenza and the pandemic 100 years ago. People looked at the SARS-1 spread back in the early 2000s, but neither of these have turned out to be really that similar to COVID. And so I think it's a good example of both the medical profession and our political leaders and our healthcare systems really having to work out what is the, let's say, the typical progress of an illness like COVID in a population, and also at a community level, what is the trajectory of the pandemic in a community, and the effectiveness with which leaders of our societies have been able to understand the implications of not acting. I think has had a big impact upon how much burden that has caused for different communities around the world.
To my mind, COVID is an opportunity to popularise the idea that diseases are not simple to understand, because there's been a lot of misunderstandings in the popular press and on social media and in wider society about what COVID is, how it affects people, and how it affects different populations differently. It seems to me that a complex systems approach that understands multiple intersecting variables that are constantly changing is a much more valuable mindset to be able to, or toolkit to be able to deploy, than the reductive, simplistic understanding of someone's infected, they'll get sick. But what lessons have we learnt from COVID that we could embrace if we are to follow the politicians' line that we need to look for a new normal?
One of the really important lessons that we've learned is the importance of understanding uncertainty, and how countries have managed uncertainty and risk, I think has been an important predictor of what's eventually happened. So some countries, and I would take Australia as an example, I would take New Zealand and Vietnam as examples, they recognized that very early on, we didn't know a lot of things, but we knew that this could get really bad very quickly. And so all of those countries took very prompt action to close off borders, to isolate populations, to do very large-scale testing, and to do large-scale community education and engagement, and to bring the people along with them. And all of those countries have been extraordinarily successful in controlling COVID. So Vietnam hasn't had, as we record this, hasn't had cases of COVID for a couple of months. Australia has had a couple of peaks, but at much lower levels than has occurred in many other countries. And New Zealand has also been very successful. And I think what that can tell us is that by taking prompt action on the basis of there being uncertainty, but but essentially, assuming the worst, but hoping the best, those countries have been able to buy themselves time to then be able to work out what was the optimal strategy. I think in some other settings where there was a lot more debate around some of the harms that might occur due to the response, I think they've sort of lost the opportunity to go and bring the pandemic under control. So I think one of the lessons here is that we need to be prepared for pandemics in the future, and that we need to be acting promptly until we work out what we need to do. And the second point I'd say is there's sort of this, I guess, advantages and disadvantages of being too focused on complexity. I think complexity has an important role because we need to understand that there is nuance, and that there is variation, and that there are individual factors. On the other hand, sometimes that can be paralyzing. And so I think in the case of Australia, for example, one of the big successes in COVID has been for us to institute a really simple, basic, standard public health measure, which is contact tracing and isolation. And that's not complicated. It's something which we've been doing for gastroenteritis, for tuberculosis, for measles, for many, many years, which is to go and test populations, isolate them, and then test their contacts, and then if they're infected or at risk, isolate them. That is really sort of epidemiology, public health 101, and it's been really effective. And I think if we had tried to wait until we had, the right, the perfect antibody test or the perfect algorithm, and we hadn't just done what we know works with infectious diseases, then I think we would have been in a lot worse position. So I guess my point is complexity is important and it is valuable, but when it comes to making policy responses, sometimes actually doing something which we know works may be more effective. And in the case of Vietnam, they in central Vietnam isolated a couple of 100,000 people in the town of Da Nang and surrounding regions because there had been an outbreak. And that was a very sort of simple, low-cost measure, but it was very effective in containing the pandemic in a setting where there perhaps were less resources to do so.
I think the point about uncertainty is one that is worthwhile sitting with and contemplating, because it's one that I personally agree with, that we are ill-equipped, perhaps, to deal with uncertainty. And I think, for me, when I abstract what you just said, some of the popular desires that we see in the media for a new normal or the next normal or a return to normal is in many ways expressing an incapacity to deal with uncertainty. It's people who have not been brought up with situations of adversity and opportunities to practice resilience in the face of uncertainty, and in the face of uncertainty, taking simple measures, think surveillance containment, community-based contact tracing, things that we know work, we should deploy. And in countries that have deployed that method, it has been very effective, even in low resource settings as well as high income settings. And I don't want to abstract what you said too much, because one thing I admire about the way in which you tackle these issues is that you are very clear about where your strengths lie as a physician and as an epidemiologist, and me abstracting them into an area of thinking about how the wider public thinks about uncertainty is an area that's perhaps a bit more difficult to tackle because we don't necessarily have numbers about that. But I am interested in your wider thoughts. I am interested in just your open reflections about normality in general. And in particular, I'd like to ask you, what questions do you think we should ask about normality?
Clearly, normality is obviously a very broad term which applies in a different way in different contexts. So I think if we look within the health context, we should be asking, first of all, what is the role of measurement of normal? Is there actually a function of it? If we're just measuring something in order to reassure ourselves, in order to give ourselves some degree of confidence that we're just like everybody else, then that may be helpful in the case of a disease, but it may be very unhelpful if everybody around you is actually also at risk as well. And so I guess reflecting on the COVID pandemic, for example, life as normal in Western societies up until 2020 over the last 100 years, but certainly over the last couple of decades has involved a lot of international travel, a lot of people mixing in large groups. that has been the expectation that we've been able to have completely free movement because there haven't been any pandemic infections. But if you actually go back in history long enough, and if you look back to the early 20th century with the Spanish flu pandemic, or if you look back in Europe in the 18th and 19th centuries with the tuberculosis pandemic that affected, perhaps a third of young people, causing a huge mortality at the time, you can see that what we regard as normal now is actually not necessarily the way things have always been in human society. So I guess one question I would say is, what time frame are you talking about for normal? And how does what we see as being normal now compare to what is normal historically in a different place or a different setting? And I think it's really valuable for us, both from a health perspective, but I think speaking more broadly as well, to try and couch our normality within context and to try and understand how our understanding of normal is very guided by our own circumstances and our own experience, and to be willing to accept that there may be other alternative normals that if we look at different people at different times and places, that we'll actually recognize how our current experience may actually be quite abnormal, from a global perspective. And I think just taking it even more broadly, if you look in wealthy societies today, where we have this expectation of health and longevity and healthcare, historically that is very abnormal, that we should even contemplate being able to live into our older life, our older age, with the expectation that we will have disease control and that we will be able to live our lives in community without having to have restrictions such as the ones we've had due to COVID. I hope that, if nothing else, that after we've got through this pandemic, that people are able to be thankful for the freedoms that they have, and also aware that we need to be not taking our so-called normalcy for granted.
I enjoy listening to these interviews over again, and I can tell this is one that I'm going to probably have to listen to a couple of times, because there's so many different interpretations of what you've said that I think is valuable to think about. In particular, the way in which you can acclimatize to a certain pattern of living, not realizing just how unique and abnormal that particular pattern of living may be, historically speaking. And it's a very good point that you make about, the last couple of decades of international travel that has been enjoyed by a small segment of the world's population, but nonetheless a very significant percentage of the global population. It's a segment of the population that is using up a lot of resources from the rest of the world in order to maintain that level of normality in their life, that kind or that genre of normality. And in many ways, the way in which this pandemic went global, and one thing I found that was interesting in Australia was some of the first patients in Australia were affluent populations, and that's not something that we see in tuberculosis quite often. In tuberculosis, which has been around for a long, long, long time, it's generally found in low-income countries, in the poorest of the poor. But in the first instances, at least in Australia, what I was observing was that it was a lot of the richer suburbs, and then it moved and shifted over time to some of the poorer areas. So when you're saying that we need to ask, what is the context of normality? And in the clinic, is it even a concept that we want to think about? Because if we are just using this as a metric of reassurance, then really we're talking about this is a metric for social re-entry. It's not necessarily a metric for biological health or biological function. And I might be interpreting what you said in a very different way, but I think it is very interesting that a lot of the time we do go to doctors for reassurance. We do get antibiotics for viruses because we want some kind of placebo or some kind of reassurance, or we want the certificate saying you're fine, or the certificate saying, yes, you have this complication, but your response to this complication is completely normal. And the propensity to normalize someone's condition, whether it's pathological or non-pathological, is interesting. But also, in a consumerist market, the propensity to make someone feel abnormal by saying they don't adhere to this metric, and then perhaps trying to sell them something, which is a very different area of medicine than lung health and epidemiology. But nonetheless, this is how that metric of normality can operate. It can operate to provide reassurance, but it can also operate to sell products to people who seek reassurance. If I'm going to summarize, and please correct me, one, is the metric of normality one that is useful? And secondly, how do we contextualize our sense of normality? And how do we make sure that that sense of normality is understood within the social, historical, and cultural moment that it exists?
I think that's a good summary. And I'd just add, let's try and take advantage of situations where we may, either as a society or as individuals, be abnormal to motivate positive change. So in the case of a smoker who has abnormal lung function tests, coming back to the start, which I was discussing around the way that we assess the person's risk of lung disease. If a person has an abnormal lung function test, it indicates they've had smoking-related disease, making sure that the person sees that as a motivated change to actually be able to prevent them from getting sicker down the track, not just to ignore it and to completely dismiss the value of that test result. And also, in the case of society, if we are in a period like we are now with COVID, that we actually take away from this a better understanding of how, as a society, we can be resilient to future challenges like this, and not just to go and simply desire to be back in the normal period again and then forget all the lessons that we've learned.
Greg Fox, I don't want to just thank you. I also want to encourage you and give you praise for the incredible work that you're doing and some of the fantastic research that you're rolling out, not just in Australia, but in other countries as well, most prominently Vietnam.
Thank you.